Hello viewers, welcome to my YouTube channel. My name is Sister Dr. Juliet Wangui Macharia. I work at Moi County Referral Hospital and I am a gynecologist. Today I wish to take you through what we call vbac. And before I continue, please don't forget to subscribe to my channel. And thank you for all the subscribers and may God bless you. So we want to talk about vaginal birth after cesarean section, or what we call trial of labor after cesarean section. So the words which you normally use is vbac or TOLAC. Yeah. So vbac is a mother who has undergone or who has previous scar want to attempt normal delivery. So she want to try to deliver normally. Why is it important? vbac is good and we like to encourage it because it has got some benefits. One of it, you find that if you had a previous surgery, that previous cesarean section, you already have a scar, and sometimes it's not easy to heal from that scar. So it takes time to heal. So if you deliver with no surgery around your belly, then you're happy. That's one of the benefits. The second benefit, there is lower risk of infection. You see, if someone cuts you or incises you to deliver you, that's a very big wound. Sometimes we just think it's just a small wound. Remember, we went all through the skin, subcutaneous layer, then we had those abdominal layers, then to the uterus. So the wound is big. Just thank be to God because it's well prepared. And sometimes it heals very fast, but you remember the pain. So there is lower risk of infection. That's another one. But again, there is also no serious blood loss. Because if you deliver normally without what we call postpartum hemorrhage, PPH, then the blood loss is minimal. So that's another advantage. But also we have a shorter stay within the hospital. You deliver today, you are okay, we observe you. And then if you're okay tomorrow, we discharge you. So there's that shorter stay within the hospital premises. So, and then we also have the patient just return to the normal daily activities very fast. This is compared to the one who have undergone another cesarean section. Remember, the one who had undergone, she had their previous scar, now we are giving her another scar, then the wound sometimes can take long. It depends with how the surgery has been done, and again, the skills used to do the surgeries, yeah. Sometimes the previous scar can have some additions, and you find that there is quite, there is a high blood loss, and again extracting the babies and all this. So we have some difficulties when it comes to previous scar cesarean sections. So vbac is good. But there's something that mothers do not understand about vaginal birth after cesarean section. So somebody is seated comfortably at home and she thinks, well, I want to deliver normally. But she has not made any attempt of visiting gynecological outpatient clinics. She has not journeyed with any doctor. She has not journeyed with any gynecology. So she has just had people saying that, you know, you can deliver normally with one previous scar. So she thinks that she's very okay. And she stays at home waiting for labor to start. And when she starts feeling some low abdominal pain or getting to the back, increase in frequency and intensity, this patient comfortably walks into the maternity. Now, when she comes, she's tough. Yeah, I don't want to deliver through cesarean section. I want to deliver normally. No. I'm not going to sign. I just want to deliver normally. I know my God will help you, will help me. I know I'll deliver normally. So it becomes like kind of friction between the doctor seeing this patient and the patient herself. But what should you understand about vaginal birth after cesarean section, or what we call trial of labor or scar after cesarean section? So these are the prerequisites that the doctor need to ask, or before you as a mother start thinking that I have to deliver, I can deliver. The doctors did not prepare me well. They just took me to theater. There's so many things, or so many some kind of misunderstanding between the doctors and the patient. So, as a doctor, when you come to me, I'll ask you, what type or what made you to, or what made the doctors to section you previously? So we have those indications which are not permanent. For example, if the baby had what we call non-reassuring fetal status, the baby was not that okay, then I can think of, okay, this one, the baby is okay. So the indication, that was a fetal indication that made this mother to be taken to theater. Or sometimes, although it's not an indication as such, but sometimes you find we have mothers being taken to theater because of meconium staining and all that, a sign that maybe the baby is tired or all that. So now this baby is not behaving like the other baby, then we can say, okay, this is not a permanent condition. You see? So I may start thinking the other way around. But there is a patient with we call it CPD, cephalopelvic disproportion. So your pelvis cannot allow you to deliver normally. So there's no way we can change your pelvis. That's how you are. So this one will automatically lead you lead me to tell you that you have to undergo cesarean section. But again, we have a mother who comes with 2 previous scars and she wants a vbac. It doesn't mean that you cannot deliver. But according to our country, any woman with 2 previous scars, she's not fit for vaginal birth after cesarean sections. So we have to deliver you. Again, if the first pregnancy or the second pregnancy, the first pregnancy you delivered normally, the second pregnancy you went for cesarean section because of maybe non-reassuring fetal status or antepartum hemorrhage and all that, then the third pregnancy you were able to deliver normally, a VBAC was successful. Then the fourth pregnancy, again VBAC was successful. So you have an attempt of 2 spontaneous delivery after cesarean section. Now you have come with the 5th pregnancy, then you are not fit. So we only allow VBAC 2 attempts. So the first normal delivery, second cesarean section, third normal delivery, fourth normal delivery, the 5th one I'll not allow you. So you have to undergo cesarean section. So we have to know your history, your obstetric history behind and what was the reason. So after understanding that, I'll also move on and ask you, do you have any uterine surgeries such as myomectomy? Myomectomy is the removal of fibroids. That one I have to ask. So if you have previous uterine surgeries, again, you are not fit for VBAC. Then another question is that, are you sure when your doctor went in and do that first cesarean section? Because most of the time we think we just see the scar outside. But the most important scar that I'm afraid of is the scar of the uterus. So I have to check, I have to ask you, whereby a number of women don't know about it. Unless you have journeyed with the doctor and the doctor knows what he or she, how he delivered you. So maybe we can call that doctor. But sometimes we have so many patients such that we cannot even remember. So if it is what we call transverse incision, then a patient may be fit for that. But if it's a classical incision, now this is the uterus. So if we cut the lower part and remove the baby, this is different from cutting your uterus horizontal this way, vertical. So if we call it classical incision. So then you are not fit for that. So now that depends with what the doctor did to you. But we rarely use classical. We normally use the transverse incision. That thing you also need to know as a patient. So always ask, what is the reason? Why are they taking me to theater? Then after you are recovering, when you are just within the hospital premises, please ask your surgeon, how did it go? What type of incision did you do? I can see it's transverse outside. What about inside? So the doctor will tell you, okay, it was again transverse. But it is always good for us as a medical officer to explain to the patient the intra-op findings after going to the surgery. It's very important. Let the patient know if whatever was you found during intra-op, was the baby okay? Did you find anything to the placenta? How was the baby line? It's very important, but rarely, sometimes we don't have that time with our patients, but it is very, very vital for each surgeon to let the patient know what happened during and what she should be prepared of after. So that is another issue. But I also I'll ask this patient to do a scan because I want to find out where the placenta is lying. So if your placenta is low lying, I'll not allow you. If you have what you call placenta previa, if you have a history of placenta previa, I'll not allow you to deliver normally. Because sometimes this placenta, if it's low lying, then it can prevent the baby, and sometimes you can also bleed too much. So cesarean section, there it's a must. So if after examining the abdomen and also doing my pelvimetry, I find this patient is not fit for cesarean section, and the way the baby is lying, maybe the baby has malpresentation, then I will not allow her. If the mother has multiple pregnancies, that's when she has twins or triplets, again, I'll not allow her if she has previous surgeries or previous cesarean section. Another thing, and a very, very important thing, which a doctor can pick even clinically, is the estimated weight of the baby while in the uterine. So we want to check this weight. So according to our guidelines, if it is more than 3.5, I'll not allow you to do it. I'll not allow the mother to do the vbac because that's a sign of a big baby. So if after examining you are less than 3.5 and then you don't have any history, then I can give a mother a chance for vbac because I know the benefits of vbac. So always take a proper history, my dear people. Don't just rush and say, this mother had one previous scar, she's fit for vbac, let us just do the vbac. No, please. Take your time. Get to understand the history of previous surgeries, obstetric history. Any scan, either she has any scan, look at the scan. And this, I want to encourage all the doctors and all nurses and all this. Let us tell our people the importance of attending antenatal clinic and what should be done. Remember, doing an obstetric scan is a mandatory. It is a mandatory. It helps us to understand. And we normally check ultrasound, we just check as a routine checkup. We have the first trimester, then the second 20 weeks, then we have to follow this patient 28 or 30 weeks. And sometimes, if she's just about to deliver, sometimes it's good. But we have mothers who don't care about the ultrasound, just come in labor and they want to deliver, they want the vbac and all this. So always talk to your patient. Let the mother, if she wants to try the vbac and you feel that this patient is fit for this, explain to her the pros and cons of vbac. Examine your patient well. If she has a closer relative with her, let this relative also know. Because remember, we don't induce. We will just allow the labor to begin. So she has a cesarean section, She has a cesarean section. She comes to you at 42 weeks. She's not in labor. Now she wants you to induce her. We don't allow that. Don't induce. She's already a post-datism. She's already out of prostitution. So let us, obstetric is not just making a decision very fast. Sometimes you do if it's an emergency. But this patient, she had a humble time of 9 months plus. She could have visited gynecological outpatient clinic, then talk to the doctor, and then they plan. So VBAC is not an emergency. It is something that has been planned and well documented. And the doctor has been journeying with this patient, trying to explain the pros and cons, the risks and the benefits of what she's about. This doctor has examined the mother. She already knows the pelvimetry of this mother. Yeah, she already knows the pregnancies, the previous pregnancies she had, any surgery. She has all the history. So this mother, if she's well prepared and the labor begins, she comes. There is communication between her and the doctor. So the decision has been made properly. So with the VBAC, even if I have journeyed with this patient, allow her to document in her file that so and so, I am Jennifer Kimani. After discussing with my doctor, I have agreed to VBAC. Yeah, after explaining to me the pros and cons, and the doctor has seen me fit for this, I am ready to VBAC. But again, I'm ready for cesarean section in case the VBAC is not successful. That's why VBAC should not be carried in dispensaries, in health centers. It should be carried at facilities where the doctors are available and we have theater nearby. The theater is just within, so that in case of uterine rupture, you just rush in. In case we need blood, we have the blood with us. In case the fetal status are not okay, we rush the patient to theater. So always think twice if you want to allow the mother to VBAC. It's not just a verbal thing. You have to journey with this patient, you have to explain to the mother, and then make that decision. So I wish all our mothers well, but don't force the doctor to allow you to VBAC. Sit, discuss. And as a medical officer, don't be so quick to allow this mother to VBAC. Understand the benefits, explain to her the benefits and the risk, and then examine the patient, then come to a conclusion, not as one person, but as a team. Let us save the life of our mothers, and we will be happy as obstetricians and gynecologists and all those who are working in maternity. May God bless us all. Please don't forget to subscribe to my YouTube channel as we keep on learning more about our health. Thanks, and God bless you all.